Well, you know, it's interesting. That was a really nice setup, and I think your audience gets an idea that there are underlying factors that increase the likelihood that if African Americans are infected by COVID-19, they have worse outcomes in the clinical setting because of these underlying conditions. But what's important to realize is that these underlying conditions, we call them health disparities, have existed for decades. And COVID-19 is simply magnifying problems that had already existed. And if we don't test in those communities, then we're not only flying blind, we're flying colorblind. So many African Americans have no idea if they're infected. The protocols in the United States are focused on people who have symptoms. And yet there are a lot of people with no symptoms who can still pass the virus around.
Stephen, you bring up an important point about the testing there. What is the possibility that the numbers are actually far worse within the black community? You talk about the difficulty of getting testing, the access, and then there's the cost of testing as well.
Well, let's just talk about the fact that when it comes to social distancing or physical distancing, many African Americans are in jobs where they can't do that. If they don't go to work, they don't eat. They're also on the front lines in our hospital systems. They're the ones potentially working in cleaning up after COVID patients have passed away. And many of those workers are concerned about bringing the virus home to their families. So I think there's an underestimate of the extent to which the infection exists in the United States in general and in minority communities in particular.
What do you think can be done then to change the situation? Is it better access to health care and testing, better self-care? And then who makes the changes?
Well, I think it's all of the above. But what's most important is that we have to change the way we're thinking completely. If anything, this virus has exposed the fact that it cannot be addressed simply as a medical problem. It must be also addressed as a social and economic problem. So we need to think differently. In minority communities, are they getting the message? And do they trust the messenger? In many minority communities, the trusted messenger may not be an MD or a professor like me. It may be a local barber or a beautician or the grocery store owner, people they trust in the neighborhood who have credibility. We need to arm those people, those trusted local people, with the scientifically sound information to communicate to their constituents. That's a whole different approach. We need to do something like you've done in China back in the day when you had the barefoot doctors. We need to turn our barbers into barefoot doctors. That's what we're working on here.